Yeah. Okay. So, for those of you who haven't heard that, I'm Dr. Tooba Sahar, and I'm here to present my case report, which was carried out in Shifa International Hospital, Pakistan. And the title of the case report is Takotsubo syndrome with underlying pheochromocytoma. And Takotsubo syndrome is actually one of the types of MINOCA. MINOCA means myocardial infarction with non-obstructive coronary arteries. And this happened in a particular patient, which was a bit rare and interesting. So we wrote a case report on it. So first of all, I would like to give a little introduction about what is Takotsubo cardiomyopathy, also known as TCC. It is often referred to as a broken heart syndrome. And it is a type of non-ischemic cardiomyopathy, and usually it happens after exposure to significant physical or emotional stress, as it leads to a release of excess catecholamines. But recently, it has been established that TCC can also be caused by other events, such as intracranial events, hemorrhage, trauma, ischemic events, acute medical diseases, and surgical interventions. It is also often encountered iatrogenically in ITU settings when we are giving patients exogenous catecholamines to maintain their hemodynamic state. And it has been recognized now officially as a distinctive form of reversible cardiomyopathy by American College of Cardiology or American Heart Association. So now I would like to talk about this particular case. In this case, a 63-year-old man presented in emergency department with chest pain, typical chest pain, radiating to the neck and associated with 4 or 5 episodes of vomiting. And the pain scale as described by the patient was 3 out of 10. And the patient in background history was significant for hypertension. And it was interesting that when the patient showed the reports that 2 months back, he complained of pain in his abdomen and outside in some other hospital. The CT was done and they told him that there's some kind of small mass in it. But at that time, we didn't have the reports. But because it was significant, the scan was repeated in our hospital. And the CT scan showed a mass, an adrenal mass in the right side, which was 10 centimeter to 9.7 centimeter. And it was having a massive effect on the upper pole of the right kidney. And because it wasn't biopsied at that time, differentials as put down by radiology team were adrenal carcinoma, atypical pheochromocytoma, or less likely metastasis from any other disease. So his ECG was done in the ER, and it showed ST segment elevations in V2 and V3. And the cardiac enzymes were also significantly elevated up to 5,000, and GKMB levels were also elevated. And because of the typical chest pain, significant ECG, and significant cardiac enzymes, it was decided by the on-call team to take the patient to the cath lab. And so the angiography was done, but interestingly, all the main coronary arteries didn't show any significant stenosis or any obstruction in the diaphragm. Echocardiography was also done, and it showed a reduced ejection fraction of 45% with severe apical hypokinesis. Now, this hypokinesis is very significant for Takotsubo syndrome. As the name signifies, actually, Takotsubo means octopus soup in Japanese, and it is because the heart assumes the shape of an octopus. So because of severe apical hypokinosis, there is it can be seen in the first image A, there is a significant squinching of the heart in the proximal part, and then there is dilatation. So it is interesting in that view. And keeping in view of the history, his images, as the coronary arteries were clear, but ejection fraction was reduced. The diagnosis was Takotsubo syndrome was suspected, and also the patient had fluctuating blood pressures, which were controlled by glycerol trinitrate infusion. And patient was discharged on oral medications, which included aspirin, doxazosine, and atorvastatin. So, but patient was discharged with follow-up with the surgical team so that they can carry out in further investigations for the mass that was noticed on the CT scan. And follow-up echocardiography was done after 2 weeks, which revealed a normal left ventricular systolic function and ejection fraction of 60%. And so it proved that it is a reversible form of cardiomyopathy, as after the surgical intervention and removal of the causative factor, the ejection fraction or the cardiac function came back to normal. And it is very important in the diagnosis of Takotsubo cardiomyopathy. After the mass was removed, the surgeon sent the sample to pathology, and the biopsy confirmed that the mass on the adrenals was in fact pheochromocytoma, and it led to the development of Takotsubo syndrome. After discharge, the BP was found to be stable of medications, and all symptoms were resolved, and patient came. So the home point is that the patient came with unusual presentation of interior wall MI with fluctuating BP, and this case was diagnosed as to be a case of pheochromocytoma. Okay, so as I mentioned initially, that most commonly this is in secondary to emotional stress, but the distinguishing feature in this patient was that this patient was a male patient, although usually the Takotsubo syndrome is mostly seen in female patients because of increased catecholamine levels. So the interesting point is that we can also, suspect Takotsubo syndrome in male patients, and with an underlying pheochromocytoma. And to diagnose a pheochromocytoma, ideally catecholamine levels should be done, which will be increased in this particular disease. Yeah, and that is the same thing. And thank you so much.